Okay, good evening. Assalamu alaikum, everyone. I hope you're doing well. Welcome to this evening's CPD session. So this is the first in our six-part series that focused on diabetes. And today we will be presenting part one, which is an overview of the disease diagnosis, classification, and management. So thank you for joining us this evening. Before we get going, I just want to draw your attention to some updates on our website. So for those of you who are attending this evening to claim your CPD points, you can now do that via the website. So this is the CPD QU Health CPD events page. Here you'll find all of our upcoming events, so we encourage you to have a look and register for the ones that interest you. Following today's event, so at 8 p.m. this evening, you'll be able to claim your CPD certification. And you'll do that by clicking on this evaluation link. So by clicking on this evaluation link here, it will take you to a evaluation form that you'll need to complete. You'll have to include the name that you would like to appear on the certificate. And once you've completed this form, there'll then be an option to submit, and we will then issue your certificate within 7 days of today's event. But please note that this link will expire after 7 days. So if you're claiming certification, please do so in the next 7 days. So at this point as well, I'd like to welcome our viewers on YouTube. So throughout today's session, you'll be able to ask your questions, submit your comments via the chat function, both in WebEx and on YouTube. And we very much encourage that interaction. We feel that it really enriches the experiences for everyone. So please contribute your comments. There's one further item I'd like to draw your attention to on the website, which is our CPD newsletter. So this is a monthly publication. If you're not currently in receipt of this and you'd like to, please let us know and we can add you to our mailing list. And our newsletter has details of our upcoming events. In March's edition, we would like to include the participant's perspective. So if you would like to share your experiences with us, what you liked, what you didn't like, areas you see for improvement, then let us know. We're keen to have a piece in March's newsletter that includes the participant's experience. So please get in contact with us after today's event if you're interested in contributing towards that. Okay, so as for today's session, we have two prominent speakers, and then there's myself. So we have Ms. Miriam Eljam from the College of Pharmacy. She'll be starting today's presentation. We have Ms. Zara Noureddin, a clinical pharmacist from HMC, and then I will be finishing today's presentation. So I think that's all I wanted to cover. I will now hand the microphone over to Ms. Miriam, and you will be able to start presenting the slides from your screen. Okay, Miriam, I've made you the presenter now.
All right, so thank you, Dr. Zakaria. Good evening, everyone. My name is Miriam Eljam. I'm a teaching assistant at the College of Pharmacy, and I'm more than happy to be starting this presentation on today's topic. So we'll start off with a little of prevalence and diabetes burden nationally and internationally, and then we'll follow with a bit of classification of the different types of diabetes. So we all know that diabetes is a major health condition or a concern globally. In fact, we have the International Diabetes Federation, which publishes a regular report that is the most recent one was released in 2019, which highlighted that over 400 million people are diagnosed with diabetes worldwide. And unfortunately, this number is expected to increase by more than 50% just in the next 20 years. We also have a collaboration between the International Diabetes Federation and the World Health Organization, which released also statistics related to how severe is the condition. So it has documented that 1 out of 11 people are diagnosed with diabetes which means that out of 60 participants that we might have today, we might end up with 5 people diagnosed with diabetes at least. And unfortunately, every 10 seconds, we have new cases of diabetes. So by the end of this presentation, over 500 people would be diagnosed with the condition. The global burden in terms of US dollars or health expenditure, it is quite significant, rising over $700 billion that is spent on the condition alone. And unfortunately, the in terms of mortality is quite also high, where we have more than 1.6 million deaths yearly attributed to the condition. Let's look a little bit more details. So in terms of global prevalence, we have a 9.3 global prevalence of diabetes that was most recently reported by the International Diabetes Federation. And unfortunately, if we look at this figure here, we note that majority of the people who are of a working group, which are between 20 and 79, are the ones at risk and have diagnosis of diabetes. So this is really an alarming statistics, and something needs to be done not just nationally, but an international level. Let's look at the MENA region, so the Middle East and North African region, where Qatar belongs. Unfortunately, it ranks the first in terms of prevalence of diabetes amongst the 20 to 79 years old. And when it comes to the number of incidences of type 1 diabetes, Qatar ranks number 8. So we see here that globally it was 9.3, the MENA region is 12.8. So it is quite high, and more efforts should be done in order to control the condition. Now, in terms of deaths, we also have the MENA region ranking the second after the African region, with over 200,000 deaths attributed to diabetes alone on a yearly basis. And these are related to less than 60 years of age. So you see that unfortunately our region, the working group, they are the most at risk, and they are most documented to have that condition. When it comes to the MENA region, what is the next expectation? Within 20 years, unfortunately, again, the MENA region is expected to maintain its rank, with almost double the number of prevalence is expected just within the next 20 years. So, and majority of these patients, again, or the diabetic patients, are actually below the age of 60 years old. And all of this is sometimes related to the sedentary lifestyle that we have within this region. In terms of the amount spent, we have Qatar ranks the first in amount spent per person on diabetes, and that's over $1,700 US. So health expenditure is alarmingly increasing as well, and a lot of this money can go elsewhere if we manage to control the condition. Because of this, Qatar has really pressured or raised the alarm and included significant changes in the health strategy. So the current prevalence that we have in Qatar is documented at 15.5, with a range between 12 to 20% in some documentation. Also because it represents the 5th leading cause of death as reported in 2014, just after road car accidents and the cardiovascular related deaths. This has resulted in making diabetes a major national health concern, placing it as a national health strategy. Hence, Qatar invested in creating a full strategy on its own that relates to diabetes. And there are 7 different items within this national health strategy that was released in 2018. We have certain concerns that the national strategy is aiming to address. This includes raising public awareness, providing information about diabetes that is easily accessible to all patients and the public, that is reliable and in a timely manner. Also having a tailored diabetes education. Nowadays, we have what is called as a diabetic educator in almost every healthcare center. So this is something that is documented within the national health strategy. The national strategy is also emphasizing on having timely services in terms of appointments, receiving services, and appropriate models of care. Also, the focus is on empowering the workforce, which means that healthcare providers are highly encouraged to attend sessions and CPD and education related to diabetes to stay up to date and maintain a standardized level of practice. Additionally, there is the work on developing an information system such as the one that we see today, like the Cerner, that is integrated amongst different institutions in order to ease the flow of information. And finally, increasing the investment related to diabetes research. Okay, so let's look at the pillars related within this Qatar National Health Strategy. We have these pillars, so raising awareness to the public, patient empowerment, care delivery, human capability, and increasing the workforce capacity, information system, as well as research. And of course, the stakeholders here are the public, the patients, the healthcare professionals, such as yourselves, as well as researchers. So where are we right now in terms of this national policy? So starting with the awareness and prevention here, I'm going just to give you a little bit of a snapshot of what has been happening since the publication of the strategy. The Ministry of Public Health now is releasing or is launching a yearly diabetes-related campaign whereby they address concerns of the public, they raise awareness, they distribute brochures. Sometimes you see them in the malls or in certain parks. There is also the Qatar Diabetes Association, which provides targeted campaigns in schools, as well as the universities and even companies, where they provide education about what is diabetes, how prevalent it is, how can we prevent it. And also we have the Hamad Medical Corporation, which invested highly in providing resources to the public. So they've dedicated a page within their website where anyone could log in and just see the information related to diabetes, starting from the signs and symptoms, even related to how to manage diabetes during Ramadan and fasting, how to self-monitor, what are the lifestyle modifications that should be done. So all of these are currently available to the public. And finally, here we have a picture of the march that they do, the walk that they usually do in Aspire Park on a yearly basis, where patients and the public are called upon to just, share what they have together, build a community of patients with diabetes, support each other. And unfortunately, due to COVID-19 in the past year, we have not seen this happen. However, there is a lot of online webinars that are taking place, some of which are by the College of Pharmacy or even through Qatar University and the Ministry of Public Health as well. So this is in terms of awareness and prevention. This is what has been done so far. The next pillar was the patient empowerment. So what has been done is basically increasing the involvement of the patient. So instead of having the patient as a recipient of care without being involved, now the practice is moving towards, including the patient in the decision-making process. There is a new application that you might not be aware of, which is called Drubi. So this application, the Ministry of Public Health, in association with the developers of this application, they've made this application available to the public or patients with diabetes here in Qatar. And a study that was recently published just in the beginning of this year highlights the positive attitude of the patients when they use this application. So with this application, they receive information related to diabetes. They can record their diabetes levels. They receive regular reminders to take their medications and more information about lifestyle modifications. So this is one initiative that was, starting to be in place for empowering the patient. We also have the diabetes education and self-management for ongoing and newly diagnosed people program. So this is a program that is initiated by Hamad Medical Corporation, where they invited patients who are newly diagnosed with type 2 diabetes to receive lectures or sessions educating them about the different aspects of diabetes, starting from the signs and symptoms, how to self-monitor, what complications, how to prevent it, lifestyle modifications, and it has shown a positive impact on the patients. The next thing here I want to highlight is basically the empowering of the healthcare providers. So on a yearly basis, we have conferences that are related to diabetes, in which the participants gain points to showcase their attendance and their participation, but also to learn about the updates happening in practice. So attending just today's webinar can represent one of these sessions where we're sharing the updates with you, reminding you of what diabetes is. So this is something that is being done on regular basis. Sometimes you find sessions related to or is organized by the Qatar Diabetes Association. Some are organized by the Ministry of Public Health, and we also have some that are organized by Hamad Medical Corporation. So we always encourage healthcare providers to attend these sessions to gain more insight about the updates and what is happening in practice. So I have been talking about the burden and the prevalence of the condition, but what is diabetes really? So diabetes is a serious long-term condition that occurs when the body cannot produce any or enough insulin. So we have this hormone insulin, which kind of opens the door for our cells to accept the glucose or the sugar from our food. Once it takes into the sugar into the cells, it changes that into a form of energy where it allows the cells to function. So whenever a patient is diagnosed with diabetes, it means that their cells are unable to really take that sugar in because of lack of insulin, or it could be that there is resistance, and this is what we call insulin resistance. Typically, a patient with type 2 diabetes, or what we term as insulin resistance, they over time may end up having a lack of insulin, and I'll explain that further once we go with the slides. So why do we care? I mean, why is it important? So what if the prevalence is 9.3 or 15 or 20? Well, it's because of the consequences related to diabetes. Unfortunately, if left untreated or not appropriately managed, the body is going to deteriorate, causing so many complications. The major ones that we care about is really the cardiovascular diseases, where we have a high increase in the risk of coronary heart disease, ischemic heart disease, cardiovascular diseases, with an alarming percentages. So some of these consequences can relate also to the kidney, what we term as nephropathy. It can also relate to eye damage, such as retinopathy, visual loss, and can even lead to blindness. And unfortunately, a lot of old-aged individuals who are not really well controlled, they might end up with a severe retinopathy leading to blindness. It can also contribute to amputations due to increased risk of infections that is not well taken care of. In terms of other consequences, we have what is known as macro and microvascular consequences. The macro is when we're talking about the stroke, the heart, while the micro is when we're talking about nephropathy, retinopathy, and neuropathy. Recently, the evidence is suggesting a link between diabetes and certain types of cancer. These can be related to liver cancer, breast cancer, and colorectal cancer, amongst others. So really the burden is not just the condition itself, the diabetes itself. When we're saying that the government or the health expenditure is at 7 billion, it's not just diabetes, but also the complication related to diabetes. So let's see if you've been paying attention with me here. Dr. Zak, maybe if you can help me, please. So we have a question here. According to the International Diabetes Federation in 2019, the prevalence of diabetes in Qatar is 2, 15, 40, or 60%. I don't think I'm able to see the chat from my...
That's fine. I can read you the answers of the participants. So if you just want to use the chat to type in your answer, you can just put a single letter A, B, C, or D. So what's the prevalence of diabetes in Qatar? So Ali thinks it's 40%.
Ali, you're not paying attention with me.
Ahmed says 15%. And we have Ala thinks it's 15% as well. Jejomar thinks it's 40%. And Muhammad thinks it's 40% as well.
Okay, so it means maybe I was talking too fast. So the International Diabetes Federation in 2019, they've documented a 15% prevalence in Qatar. Now, this is a range between 12 to 20, depending on the reference that you read, but 40 is a bit too much. Just think of a class that you have of 10 people. If it's 40%, it means 4 out of 10, they have diabetes, and that's quite, significant. But the actual percentage is 15%. The next question here I have for you is something maybe that I went a bit too fast on, is within the MENA region, Qatar ranks which of the following in the incidence of type 1 diabetes in children? First, 8, 12, or 13? just give you a few seconds there.
Okay, so where does Qatar rank in terms of incidence of the incidence of type 1 diabetes in children? So Raj thinks that we're first in the MENA region. Bina also thinks that we're first. Fatima says that we're first as well. Muhammad says we're 8th. Alat says that we're first as well. So I think the majority thinks that we're first in the MENA region.
Luckily we're not the first, but rather it's the 8th. Okay, so it's still quite high, not the first. The first is actually Finland globally, but within the MENA region, it's actually the one that comes before Qatar is Kuwait. Okay, so we're not really the first. All right. So let's talk now about the classifications. The most common classifications that we know is type 1 diabetes, type 2, and the impaired fasting glucose or impaired glucose tolerance. Sometimes it's included within the classification, sometimes it's termed pre-classification or pre-diabetes, sorry. And we have hyperglycemia in pregnancy, which is interchangeably used with the term gestational diabetes. And more recently, we're seeing the term monogenic diabetes. Now, these are not conclusive. These are some of the classifications you might see in the literature. So let's just give you a little bit of information about each. So in terms of type 1 diabetes, it's just around 10% of all of patients who have diabetes. It's only 10% who are likely to have type 1. It is not quite common. However, the incidence is the highest among children and the young adults. We still see it happening in older adults, but not as common as when it comes to children. The exact reason behind the pathology or the cause of the condition is not really well known. However, there is evidence for genetic susceptibility. And whenever the evidence is suggesting that whenever a mother has diabetes, there's a chance of 4% that the offspring would have diabetes. If it's the father, the percentage can go up to 8%. And if it's both parents, the percentage can actually reach 30%. So there is evidence for genetic susceptibility. When it comes to type 2 diabetes, it is it's the most common type. 90% of patients with diabetes, they are more likely to have type 2. And it really relates to our sedentary lifestyle. The food we eat, the lack of exercise, the being overweight, family history, all are risk factors for type 2 diabetes. And generally speaking, it's characterized initially with insulin resistance, whereby the cells, they are unable to take in insulin. And so we have a high level of sugars within the blood. This sends a signal to the brain, to the pancreas to release more insulin. So over time, the pancreas is releasing insulin over time, more and more and more, up until it gets exhausted. So it no longer, releases insulin. And this is why a lot of patients with type 2 diabetes, they may end up on insulin at the end. One thing that I didn't mention with type 1 diabetes, it is insulin dependent. So a patient really cannot go about their days without receiving insulin. And when it comes to type 2 diabetes, it is more common in adults. However, recently, and it's very unfortunate that we see it happening also in younger children due to the sedentary lifestyle. The next classification is basically what I said in the beginning. Sometimes it's not listed under the classification, but rather termed as pre-diabetes. And this is what we call impaired glucose tolerance and impaired fasting glucose. So patients are having high blood sugar, but it's not high enough to reach the diagnosis of diabetes. So for the impaired glucose tolerance, basically after receiving 75 grams of glucose, you measure their sugar level. If it is between 140 and 200, so they're not at the above 200, this is what is called impaired glucose tolerance. And for the fasting or the impaired fasting glucose is basically after 8 hours of fasting, the patient would have high readings, but it does not qualify to the level of diabetes. So they're still below the 125 milligrams per deciliter. The risk factors are the same as the type 2 diabetes, so the sedentary lifestyle. And actually, the IGT and IFG, or the impaired glucose tolerance, and the fasting glucose, the impaired fasting glucose, they are themselves risk factors for developing type 2 diabetes or even gestational diabetes. So the next classification that I have here for you is the hyperglycemia in pregnancy. And if you notice here, I did not call it gestational diabetes. This is because the World Health Organization, they classify hyperglycemia in pregnancy into two different categories. We have the gestational diabetes or the diabetes in pregnancy. And the difference between the two is quite simple. So if a woman, during her pregnancy develops diabetes, it is termed gestational diabetes. And if she is already diagnosed with diabetes and became pregnant, this is what we call diabetes in pregnancy, or DIP. One thing to highlight is patients who have gestational diabetes, it's transient most of the time. So by the end of the pregnancy, the blood sugar goes back to normal. However, evidence is suggesting that within 3 to 6 years post that diagnosis, the patient is likely to develop type 2 diabetes. This is of major concern during pregnancy because it is a risk factor for certain complications, such as preeclampsia, large for gestational age infant, which can cause problems for the delivery, prenatal mortality, perinatal mortality, fatal or neonatal cardiomyopathy, and amongst others. So this is why it's very important that a patient who is pregnant to get tested for gestational diabetes. Some of the risk factors, as we said, the impaired glucose tolerance or the impaired fasting glucose is one of the risk factors for gestational diabetes. Having a family history, certain ethnic groups may have higher risks compared to others. Family history, the pregnancy weight, the higher, the more likely the risk is. Older maternal age, so some document that above 30 maternal age is a risk for gestational diabetes. Also having a previous birth of an infant of over or equal to 4 kilograms. So all of these are some risk factors for gestational diabetes. The other classification that I want to highlight is basically what is now being talked about quite in the literature is the monogenic diabetes, which is really a result of a single gene mutation rather than a combination of genes. So the combination of genes, we see that with type 1 or type 2, but a single gene, this is what we call a monogenic diabetes. It is quite rare, not very common, and really to confirm the diagnosis, you have to do genetic testing, which not a lot of people do, and so it is a lot of times misdiagnosed as either type 1 or type 2. There are two categories defined. We have the neonatal diabetes, and we have the familial diabetes, or otherwise known as MODY, or maturity onset diabetes of the young. The neonatal diabetes, it is also subdivided into transient or permanent. A lot of times when the baby is born, it's usually within the first 3 to 6 months that they are diagnosed with monogenic diabetes if they do genetic testing. And if it is transient, within 1 year, the baby's health is back to normal. If it is permanent, then a different way goes in terms of treatment depending on the gene that is affected and the presentation of the condition. And we'll see here, I have for you a table that kind of highlights the different genes that were identified from the literature and from research. So here are some examples for the neonatal diabetes. As you can see in the middle column, it says here permanent or transient. And there is differences depending on the gene and the way the clinical presentation it is. So again, the monogenic diabetes is quite rare, not very common. Majority of cases are transient, and whenever it is permanent, the presentation determines basically the treatment. For the familial, this is another table, and the most common form that is documented is MODY 3. So this is the one here, and it's it presents as an early onset, low renal threshold for blood sugar. Microvascular complications are often seen with this type of diabetes. These are the major classifications that I've spoken about. There are other types of diabetes that I did not touch upon. It is quite rare, but these are just for your information to raise your awareness level. So we have diabetes that is caused by a condition in the pancreas, such as pancreatitis, trauma, pancreatic cancer. We have also diabetes due to endocrine disorders, such as polycystic ovarian syndrome, which can also be correlated with diabetes. We have also the drug and chemically induced diabetes, such as in patients who are being treated for HIV, receiving certain drugs, patients who are taking long-term glucocorticoids at high doses, patients who are being treated for organ transplants for certain drugs as well. We have also infection-related diabetes, certain viruses that attack the pancreatic cells and hence affect the production of insulin. We have also uncommon specific forms of immune-mediated diseases. So certain immune disorders, they can cause diabetes. This is apart from type 1 diabetes. And finally, we have also the other genetic syndromes, such as a patient with Down syndrome or Friedreich ataxia syndrome. So these who have certain genetic predisposition. So this is it for the classification. Let's see now if you remember anything from what I've said. So the question here, it says, which of the following diabetes classification does the following fit into? So if you have a patient who is taking high doses of glucocorticoids for a long period of time, which of the following is the most likely classification? Type 1, diabetes related to endocrine, chemically induced, or genetic? That's an easy one.
Okay, so we have our participants typing their responses in the chat. So Hassan seems to think it's the drug and chemically induced diabetes. Fatima also says C, and Alat says C. Muhammad says C as well.
Very good.
Jajamar, so it looks like everybody's saying C, Ms. Mariam.
Very good, very good. So yes, it is drug and chemically induced. That's a very easy question. The next question here, let's say if you have a patient with Down syndrome who presents with hyperglycemia, which of the following is the most likely diagnosis or classification rather? Type 1, diabetes related to endocrine induced, or genetic syndrome? Again, these questions are easy just to kind of keep your attention.
So Muhammad is saying D. I think Muhammad's doing very well today with the answers. Jajamar is saying D. Alat is saying D as well, and Hassan is saying D. Raj is saying D, and Bina is saying D. It looks like everybody is saying D, Ms. Mariam.
Very good, very good. So very correct. It's a genetic syndrome-related diabetes. So this is it for me. I hope I gave you a good understanding of the burden, the prevalence, the national strategy related to diabetes. And now I leave it to Dr. Zahra to tell us a little bit more about the diagnosis.
Okay, many thanks, Ms. Mariam. So, Ms. Zahra, I'm just going to share the screen with you. Hang on one second.
Hello. So just my slides are just here. Just bear with me. Okay, just 1 second. Okay. So just start by introducing myself. My name is Zara. I'm a clinical pharmacist at Qatar Rehab Institute and Hamad. So just carrying on from where my colleague Mariam has left off, I will be talking about the objectives for the slide. Just bear with me while I actually fix the slides. 1 second. Okay. So first of all, we're going to talk about the signs and symptoms of type 2 diabetes. So we'll talk about the clinical presentation. So what are the typical symptoms you see in a patient who presents with type 2 diabetes? We will talk in details about the diagnostic criteria. So we'll talk about the diagnostic tools, how do we screen for diabetes and differentially diagnose it from the other kinds that my colleague discussed earlier. And the last thing we'll discuss is the diabetes prevention. So when the patient is at that stage where he's pre-diabetic, what do we do to prevent the progression of the disease from pre-diabetes to diabetes? Okay, I do tend to speak fast, so please slow me down if you think I'm talking too fast. And also, if you do have any questions, also please feel free to unmute your mics and ask me throughout the presentation. Okay, so we'll start with the clinical presentation. So as you can see highlighted here, a lot of the patients that have diabetes are asymptomatic. Now, the reason behind that is that we've become very good at screening, both nationally and internationally, that now diabetes is diagnosed early on in the disease stage. So before it gets to the symptomatic phase, we are screening the patients early, so we are diagnosing them early before they reach that stage where they become symptomatic. Now, as you can see in the slides, in this picture here, these are the most common symptoms of diabetes if they present in that situation. So first of all, we have excessive urination. So we know this is referred to as polyuria. This is obviously when you frequently go toilet, both daytime and nighttime. You also have polydipsia, which is increased thirst, more than usual. You feel thirsty a lot of the time. You're feeling tired, drowsy, hungry, and you might lose some weight. Now, on the next slide, I'm just going to show you this graph. So just to actually explain what happens, so what's the reason behind polyuria and polydipsia? So as you can see here in this graph, the horizontal line is the blood glucose concentration, and the vertical line is the renal glucose transport. So that's how when the kidney is basically normally is reabsorbing the glucose from the bloodstream or from the filtrate back into the bloodstream. Okay, so I'll just use the colors of the lines to explain. So first of all, you see the red dotted line. So this is the kidney reabsorbing the sugar back into the bloodstream. And then you've got the yellow line, and this is the kidneys excreting the sugar. Now, the key point here is here at 10 millimoles per liter. Once the blood glucose exceeds 10 millimoles per liter, you'll see that the red line starts to plateau. You can see here the reabsorption stops. So that means we have reached the maximum renal threshold. So the kidneys can no longer reabsorb glucose. So as you can see with the yellow line, that we're starting to excrete glucose in the filtrate, which means that we're excreting it in the urine. Okay, so this is important to remember that we do have a renal threshold for a glucose reabsorption. That's 180 milligrams per deciliter, which is equivalent to 10 millimoles per liter. So after that, like I said, you're going to start excreting the glucose in the urine. As we all know, this creates a hyperosmolar filtrate. So that means the glucose will draw or attract the water into the filtrate, so that increases the volume of the urine, and this explains why you'll use the toilet frequently, but also causing hypovolemia, and hypovolemia will cause you to activate the thirst mechanism, and that's when you start to get thirsty. Okay, so this explains the pathophysiology behind the polyuria and polydipsia symptoms. Now, if you just go back to the slide, this one here, the yeast or bladder infection on this picture, just to also briefly explain that. So as you can imagine, you're now excreting glucose in the urine. Infections, opportunistic infections such as fungal infections or UTIs, they love sugar. So the fact that now you have sugar in your urine, you're storing it in the bladder or you're passing it through the urethra, it increases your chances of getting infections. So a lot of the times in females specifically, we have females presenting with recurrent fungal infections. And the first thing we do screen them for is diabetes, because obviously it's an opportunistic infection and you want to rule out diabetes in such patients. Okay, so like I said, nowadays you don't really get much patients presenting with these symptoms because we're screening earlier on in the disease pathway. Okay, so moving on. So well, now we're going to talk about screening. But before we get into the diagnostic criteria, we're just going to have a look at this. So the World Health Organization has provided 5 criteria that basically deems a disease eligible for screening. Okay, so we'll talk about each point and relate it to diabetes. So first of all, we have that the disorder is an important public health problem. Number 2 is it has an early asymptomatic stage. There's a suitable screening test. A treatment is available, and that it has, if we treat it early, we can prevent progression. Okay, so this is the World Health Organization classification. Now, if we apply it to our disease, so first point, is it a problem, an international problem? Yes, of course it is. So as we know, as my colleague Ms. Mariam discussed, that the International Diabetes Federation estimates that about 463 million people living with diabetes in the world. And they estimate that this number is going to increase to 578 by 2030 and 700 million by 2045. So as you can see, that the prevalence is increasing, and this is obviously a big problem both nationally and internationally. Okay, so again, the next point is that it has a long asymptomatic period. So as I already mentioned, before the patients start presenting with symptoms, they're going to be asymptomatic for a while. And this is the period where we have to target that screening so we can actually pick up on that disease early on before it progresses and becomes more difficult to manage. The third one, that we have screening tests, and yes, of course, we have screening tests for diabetes. We have screening tests for diabetes, and well, we've got 3 we're going to talk about in detail. So we've got the HbA1c, which is the glycated hemoglobin. We've got the fasting plasma glucose, and we've got the oral glucose tolerance test. So I'm not going to talk about those now because I will cover those in details later on. The fourth point is that we have treatment for diabetes, and yes, of course we do. There is a study, it's the UK prospective diabetes study. It showed that if you do improve glycemic control, so if the HbA1c is controlled throughout the course of your diabetes, you are less likely to develop microvascular disease, so things like retinopathy and neuropathy and things like this. And this is an important point. So this is why we do try to monitor patients who are being treated to make sure that their glycemic control is actually good, because this will prevent complications later on. And finally, if you intervene early on, so if we detect patients at pre-diabetic phase, we can actually prevent that progression by early intervention. So things like lifestyle modifications, weight loss, dietary modifications, and things like that. We will discuss again later on in this presentation. Okay. So who should we screen for diabetes? So we've got the American Diabetes Association. This is taken from their guideline. They have provided basically a list of patients who are deemed to be at a high risk of developing diabetes or prediabetes. Okay, so as you can imagine, anyone that's overweight, so BMI more than 25, or obese, so BMI more than 30, that presents with an additional risk factor. So for example, let's say you have a mom or dad that's got diabetes, so first degree relative, you've got a history of cardiovascular disease, you're hypertensive, your lipid profile is out of range, or you basically inactive, you have a sedentary lifestyle and you don't do much physical activity, then you are at a high risk of developing diabetes. Okay, now as such patients, we have a risk tool that we'll discuss basically to assess what their likely risk is and whether or not they should be formally screened. But these patients are considered to be high risk of developing diabetes. Now, patients that have pre-diabetes, again, we'll talk about this later. So patients who are pre-diabetic, they need to be screened every year. So you want to make sure that the pre-diabetes has not progressed to diabetes. And also patients who develop gestational diabetes during their pregnancies, they will need to be screened every 3 years, because again, the risk will increase. The risk of developing diabetes during their lifetime will increase. Everyone else, for regular patients, Once they reach 45, then we recommend that they start getting screened after the age of 45, and then after that, every 3 years, unless obviously things change or their clinical status changes. Okay, so from the slide, just bear in mind is that the weight of the patient is a very important factor. So their BMI, along with other risk factors such as cardiovascular disease, hypertension, physical inactivity, and a deranged lipid profile. Okay, now to simplify things, the CDC, in collaboration with the American Diabetes Association, have created this risk test. So they call it the 6-minute risk test. I'm not sure why 6 minutes, not 5 minutes, but I think it takes 6 minutes. So if you look at the questions, it basically predicts the risk based on demographics and clinical information. So like we discussed, it asks you your age, your gender, because there's evidence that males are at a higher risk of developing diabetes than females. It asks you whether you've had gestational diabetes, only obviously if you're female, whether you've got family history, and again, this last point here is what's your weight category. So as you can see here, it basically calculates your BMI for you. And the higher the BMI, the more points you get. And it's not a good thing. Okay, the higher the score, that means the higher the risk. Okay, so as you can see here highlighted, scores that are more than 5, they should be formally screened for diabetes. So if you have a patient or you yourself want to check, you can fill this quickly. It takes 5-6 minutes, and then you get your score. And based on that, you can decide whether or not you want to go get tested. Okay, again, if it's more than 5, then it's recommended you go to the doctor to get formally screened. And what do we mean by that, formally screened? So that means you take one of those screening tests. You've got the fasting plasma glucose, the glycated hemoglobin, the oral glucose tolerance test, or sometimes they use this one here. So number 4 is basically when you just go to the doctors and they measure your random glucose and it is above 11.1, but also you're presenting with hyperglycemic symptoms. So the symptoms we spoke about earlier in the presentation, so polyuria, polydipsia, weight loss, then this might be sufficient for diagnosis. However, again, we don't really see this much in practice anymore. We don't really see patients presenting with this kind of symptoms. So the main screening tests are the first 3. Okay, here, as you see in this last point, that measurement of urine glucose is not recommended. So when diabetes was first discovered, the way they used to diagnose it was by tasting urine. And if it's sweet, then they diagnose the patient with diabetes. So luckily, we don't do that anymore. And again, it's insensitive to detecting type 2. So even if you do measure your glucose in the urine, it's not going to be an accurate way to screen it. Okay, so let's talk about each of those screening tests. So first, we'll start with the fasting plasma glucose. From the name, it's quite self-explanatory. Fasting, so obviously you've had the fasting period of at least 8 hours. You haven't eaten, you haven't had any caloric intake, so that's just basically you've had water. And after the 8 hours, they go and either do a finger prick test or they do a blood test of the plasma glucose. And based on that result, as you can see in this diagram, if it's above 126 milligrams per deciliter, which is equivalent to 7 millimoles per liter, then you meet the threshold for the diagnosis of diabetes. Doesn't mean you're 100% diabetic. It means that this is the first step. So we've got one result that meets the threshold for diabetes. Okay. Now, for any of these tests that we'll discuss, you need at least 2 results that meet the threshold of diabetes. So you either need to have 2 separate fasting plasma glucose screens done, or you have one of a fasting plasma glucose in addition to another test that meets the criteria. So the key here is you need at least two occasions where the result meets the threshold for diagnosis of diabetes before you can confirm the diagnosis. Okay, now advantages for this one is that the assays are inexpensive, and some patients prefer this one because you can simply just go to the clinic, get a finger stick test, and basically the result is available within a few seconds. So you don't need to wait for the blood results to come back, or you can just get the result there and then. Now the disadvantage with this one is that because you're measuring the glucose level there and then, you're basically not taking into account things like stress. For example, if the patient's stressed, as we know, you've got steroid release, and steroids can cause hyperglycemia. So that might give you a misleading result. Or if the patient, for example, fasted for 12 hours, or patient fasted 8 hours, would that be analyzed the same way? So some patients come in, they fasted for 10 hours, so the duration of the fasting will also have an impact on the fasting plasma glucose level. The other point here is diurnal variation, and that basically means the difference between morning and nighttime. So for example, if you work a night shift and you are unable to do the fasting plasma glucose in the morning, you can fast during the day, and you have an afternoon fasting plasma glucose. So that will differ because the morning and the nighttime sugar levels are going to differ. Okay. You also have person variability, and the sensitivity may be lower for people over the age of 65. So these are some of the disadvantages, and this is why we don't take one result in isolation. You need to have at least two results in order to confirm the diagnosis. Okay, the second screening test is the glycated hemoglobin. So as we all probably know as HbA1c. So just to give you a little bit background, I'm sure you're all aware of this, but just to recap. So we got a red blood cell, and the red blood cells contain hemoglobin. So each red blood cell has 4 hemoglobins, and hemoglobins, they're the oxygen carrying molecules. So they bind oxygen and they transport oxygen around the body. Now, the normal hemoglobin is normally free. It's not connected to a sugar. However, the red blood cells, they're permeable to glucose. So if the concentration of glucose in your blood is high, the glucose will simply passively diffuse into the red blood cell, and it will attach to the hemoglobin. Okay, and this is what this measures. So the glycated hemoglobin is basically a form of hemoglobin that is linked to a glucose. Okay, and if this is present, you're indicating that we have excess amount of glucose in your blood. Okay. So the measure itself determines the 3-month average plasma glucose. And the reason it's 3 months, because a red blood cell lives for 120 days. So the life cycle of a red blood cell is 3 to 4 months. And the bond between the hemoglobin and the glucose is irreversible. So once it's bound, and this 3 months is over, the red blood cell obviously dies, and you have a new one. So when you measure the HbA1c, you're measuring that average in the past 3 months of the glycated hemoglobin. And this could be used as a screening test. So if someone comes in and you request the HbA1c, it gives you a good indication of what the glycemic control was like in the last 3 months. So you could use it as a diagnostic tool. So as we can see in this image, the threshold is 6.5. So any person with HbA1c of 6.5 or higher, then this is diagnostic of diabetes. Now, the higher, the worse the glycemic control. So sometimes I have patients presenting with HbA1c of 11.5 or 12 or 13. So obviously this is quite an indication of how poorly their diabetes is, or how poor their treatment is. It gives you also an idea of the adherence to the treatment. So it's not only diagnostic tools, we do use as an assessment of a glycemic control, but it also used to monitor efficacy. So if we get a patient started on, let's say, metformin and sitagliptin, and they go home, we don't really know what the sugars are like at home, they don't monitor themselves, and they come back in 6 months, we repeat the HbA1c. If it's still the same, obviously there's something wrong, either the patient's not adhering or the treatment is not working. And then from there, we can monitor the efficacy and adjust the treatment if we need to. Again, to reiterate, so A1C more than or equal to 6.5%. We tend to use percentages more than the millimole per mole concentration, but I put it in there just in case some of you rely on that kind of a measurement. We use percentages, so above 6.5 or 6.5 is diagnostic. Now this is important. Now HbA1c is standardized internationally, and the assays have to be certified by the NGSP. So that's the National Glycohemoglobin Standardization Program. Now this is a good thing, because obviously that means the result you get is quite reliable, and it's internationally it's an international program. So that means if you measure HbA1c in this lab or a different lab, it should be quite reliable, like I said. Okay. So advantages of this one. So it's convenient for some patients, because some patients don't like to fast. And if the patient is presented, for example, to your hospital, you can request an HbA1c there and then. At any time of the day, it can be requested. It's standardized, like I said. There's less day-to-day fluctuation. So as we said, the fasting plasma glucose is affected by acute glycemic changes. However, this one is not, which is it's a good one to use alongside the fasting blood plasma glucose. There's a strong correlation with retinopathy and other complications. So if the HbA1c is high for a long period, like I said that to you, the UK prospective study proved that actually proves that later on you will have worse microvascular complication if your HbA1c is poorly controlled. And it's a reliable measure of chronic hyperglycemia. Now, the disadvantage is more costly. And also, you want to think about the developing world. They might have limited availability, so they might not actually have the same advantage that we have easy access to this test, so they might not have this. And sometimes it might have lower sensitivity at the cut point. So for example, the 6.5 exact cut point or the 5.7, that the sensitivity might be a bit lower. But despite this disadvantage, it is really our mainstay screening test that we rely on in the hospital to diagnose diabetes. Okay, the last one is the oral glucose tolerance test. Now this one, we don't really use much. This is the one that is used to diagnose gestational diabetes mellitus. So patients that are pregnant get to do this. I've done this. It wasn't a very nice experience because they get you to drink 75 grams of glucose dissolved in water. So obviously you can imagine that's very sweet, and you have to do it first thing in the morning because you want to have a fasting state. So the first level they take is the fasting, and then you drink the syrup, and then they measure your glucose after 1 hour and then after 2 hours. So the reason they do this is because they want to basically graph the result and see how your body responds to that sudden intake of sugar. And if we do use it, if the patient is not pregnant and we do rely on this level, which we don't again in practice do much, then we look at after 2 hours what the level is. Okay, so if the 2-hour plasma glucose is more than 11.1, which is here on the diagram equivalent to 200 milligrams per deciliter, then that is indicative of diabetes. Again, this is just for completion's sake. Like I said, in practice, we don't really use this much. The two main ones we use are the fasting plasma glucose and the HbA1c. Okay, so I've just put here a summary from the ADA that basically discusses the diagnosis of diabetes, what we spoke about. So the first one is the HbA1c is more than or equal to 6.5, or a fasting plasma glucose of 7, or a 2-hour or a glucose tolerance test that is more than 11.1. Okay. Again, we don't take one result in isolation. It has to be 2 results that meet the criteria to confirm the diagnosis of diabetes. And in practice, we always take the HbA1c, and we always take alongside a fasting plasma glucose. Okay. Again, this is the practice in the hospital I work at. So this might be different in other hospitals, but this is what we do. Okay, before we move on, I just put a case study here. So a 44-year-old Indian patient, actually this patient is one of my patients. There's no identifications or anything, but this is a real example. So a 44-year-old Indian patient is admitted to hospital with back pain, fever, and night sweats. On admission, his random blood glucose was measured to be 12 millimoles per liter. The resident you work with documents this patient as a newly diagnosed diabetic. Got nothing against residents, this is just an example, okay? So do you agree with the resident and why?
So I'm going to help you here with the chat. So we have from Ala or Ala, I'm not sure. He says no. Let's see the others. One reading is not enough, according to Ala.
Okay.
Jajomar, we have, he's saying option B, also no.
Okay, perfect. So yes, that's right. Thank you guys for contributing. So the answer is no. We don't agree because we can't take one result in isolation. Just because he's got a high plasma random blood glucose does not mean that this patient is diabetic. If you look at the symptoms, so he's got back pain, fever, and night sweats. These are not typical symptoms of diabetes. If these were polyuria, polydipsia, and fungal infection, maybe you could possibly use that. However, because these are not really related to diabetes, we cannot say that this patient is diabetic based on that. Okay, so no, yes. Next question. So as part of your medication reconciliation, You interview the patient and he tells you that he just completed a 2-week course of dexamethasone for a lesion on his back. So what are your thoughts? So this patient definitely has diabetes. This patient needs to carry on with his steroid course. This patient needs further tests to rule out diabetes, and the patient might be experiencing a side effect of the steroids. You can have 2 answers, A and D or C and D.
We're waiting on the participants to write their answers in the chat.
It's okay. Take your time.
Ala says option F.
Okay. Anyone other than Ala that's paying attention?
We also have Jijimwar, also option F.
Okay. Anyone else? Does anyone else think it's not option F?
And Alia, also option F.
Okay.
So I think they all agree on option F.
Perfect. So it's option F. That's correct. So the patient needs further tests. Like we said, 1 is not enough. And also, like we also said, steroids can cause hyperglycemia. So this might be steroid induced. Okay, so the last thing, you requested the HbA1c and the result comes back as 6.1. What do you inform your resident? Patient has type 2 diabetes, patient has pre-diabetes, patient is healthy, you're not concerned, or you require more tests before you can confirm a diagnosis.
We have Muhammad, he's saying option B.
Okay.
So patient has pre-diabetes.
Okay.
Ala says the same thing. Pre-diabetes, Alia, same thing.
Okay. So it's actually 2 right answers. So we can say the patient is pre-diabetic. However, because the random plasma glucose was high, we still need another, although it was high, but the patient was taking steroids, this might actually be related to the steroids. So normally the effects of steroids on plasma glucose, they go away within 2 to 3 days. So what we can do is we can wait 2 to 3 days, and we can repeat a fasting plasma glucose in order to confirm the disease. Although in this situation, the HbA1c is not really a measurement that's going to be affected by the recent glycemic fluctuations. However, like we said, we still need 2 screening tests that meet the criteria before we can say 100%. But because it's pre-diabetes, we don't really need to intervene at the point or initiate treatment. We can wait a few days and repeat the fasting plasma glucose. And then if it meets the threshold, then we can say that the patient has pre-diabetes. Okay, thanks everyone. So just to move on now, that leads us on to pre-diabetes. So from the name is pre-diabetes, that means it's the stage just before you actually develop diabetes. And if we look at the screening tests that we discussed earlier, we're just going to see the first one is the fasting plasma glucose. So the pre-diabetes is this orangey color. So as you can see, it's between 5.6 millimoles and 6.9 is when you would say that if the fasting plasma glucose falls in this range, that the patient is pre-diabetic. Now, some people use I think Miss Mariam also discussed this in her slide, it's referred to as impaired fasting glucose. And this is basically when the fasting glucose falls in this range. When the glucose tolerance test is taken and it falls after 2 hours, the levels are between 7.8 and 11 millimoles per liter, then this is prediabetes, and this is referred to as impaired glucose tolerance. Okay, so if someone say they have IGT, that means they've done the oral glucose tolerance test and the patient's results fall in this orangey range. And the last one and the most useful one is the HbA1c. If it's between 5.7 and 6.5, then the patient has prediabetes, if it's again confirmed with another test. Now, why is it important to detect this early on? Because as I said earlier, the progression of the disease could be slowed down if you can screen early and you can diagnose early. Okay, so this is just a risk factors chart, basically the modifiable and the non-modifiable risk factors. So if you have prediabetes and you're old, or you're a male, or you have family history, obviously these are things you have no control over. So these are already part of your risk score. However, the things you do have control over is your physical activity, your weight, your control of your blood pressure, whether you smoke or not, and your lipid profile. So the modifiable risk factors is what we aim to target when the patient is pre-diabetic. These are the things we try to work on to delay the progression of prediabetes to diabetes. Okay, so prediabetes again is an important risk factor for cardiovascular disease. It's important to identify it early because the earlier you intervene, the slower the progression of the disease. I'm not saying that it always works. Obviously, we have a lot of cases pre-diabetic and they progress quite quickly despite our lifestyle interventions and the modifications that we try to help them with. So the first line for pre-diabetics is lifestyle modification. So that is the primary intervention. Okay, so you recommend that patients lose weight 5 to 10% of body weight. So obviously, if we said that the patient is overweight, so if the BMI is more than 25 or obese, so the BMI is more than 30, it is recommended that we basically we encourage them to lose that weight. Now in the hospital, when we have patients that are in the hospital, they're inpatients, they have access to a lot of help. So we have dietitians that are amazing. Dietitians help the patients lose the weight. They put them on diabetic diet, which is obviously lower calories than the normal diet, less sugars, less salt, less red meat, and they help them lose that weight. Again, we have they try to get them to exercise, so 30 minutes a day. The recommendation is 30 minutes approximately on 5 days of the week. Obviously, this is a recommendation for everyone, whether they're pre-diabetic or not, but we try to obviously reinforce it with the pre-diabetic patients, and smoking cessation. Okay, so again, to just like I mentioned, exercise 30 to 60 minutes of moderate intensity on most days of the week. Patients, I know this sounds easy to say, but patients find this very hard to do, especially as it's actually a lifestyle change. So someone that's never exercised in their life, now all of a sudden they're 50 and you're telling them they need to walk for 30 minutes, they find it very difficult. So you need to assess the patient, you need to assess at what stage of that cycle of change they're at. Are they ready to change? What interventions? Is it behavioral at first and then you do the action, or are they actually ready to take an action and take control of their health? So that's down to you, whether you're a pharmacist, your nurse, your dietitian. We all play a big part in this, in helping patients. And the next one is diet. So I've got a few examples. I've discussed this with the dietitian that I work with. So like I said, we do put patients on diabetic diets, and what that means is that it's a lower calorie intake, low in sugars, high in fruits, vegetables, maybe a lower amount of rice, which some patients are not happy about, but we try to help them by putting them on that diet. Now, another diet we sometimes we do recommend when the patients leave the hospital is called the DASH diet, and this is the diet recommended for hypertensive patients. So it's the dietary approaches to stop hypertension. And this one is could also be used for diabetics. It's got the similar concept where you have less sugars, you have lower salt intake, less red meat, and basically a higher amount or servings of fruits and vegetables, and you try to use low-fat dairy. So we try to recommend this for the patients. Again, like I said, the dietitians in the hospital, they're the ones that counsel the patients on discharge and try to guide them in that direction. But also as pharmacists, we try to also have an input when possible to try to help the patients. Okay, so if the patient is pre-diabetic and they do the diet, their exercise, and they're actually doing well, we repeat their checks every year. So we try to do an annual screen to make sure that they're still in that pre-diabetic phase, or actually maybe their HbA1c is even improved and they're no longer in the pre-diabetic phase. So you just want to make sure that they did not progress to diabetes. However, in certain patients, so if they have a high BMI or they're less than 60, then they're at a higher risk of actually progressing quite quickly. And in these patients, again, it's a higher risk that the lifestyle interventions will fail. So like I said, a lot of the patients, despite the interventions we try to do, they don't lose weight, or the adherence is poor, or you have people that are not actually willing to do that change. So I do have a patient that is not basically in control. He does not want to lose weight. He's not sticking to the diet. He's on probably the highest insulin dose I've ever seen. He's probably on like 90 units twice daily, and despite that, he does not want to change. So you do have this, difficult patients. If that patient is pre-diabetic and has such risk factors, the ADA does recommend we start them on metformin even before they get to the diabetes phase. And there's evidence that early initiation of metformin can actually also delay the progression to diabetes. So if we do start metformin, we need to have at least annual monitoring once the patient is stable, recheck the HbA1c, and see whether they develop diabetes or not. Okay, so this brings me to the end of my slides. I will leave you now with Dr. Zakaria. Thank you, everyone, for listening. 1 second. Okay.
Okay, thank you very much, Ms. Sahara. Very informative presentation. So at this point, I just want to see if there's any questions from our audience. Okay, so at the moment, it doesn't look like there's any questions.
I think we have one question. So regarding the fasting blood glucose, we can't use the finger prick test to diagnose diabetes. Fasting blood glucose should be plasma blood sample. That's the question? You know, we cannot really use the finger prick, or can we use it?
Okay, so the question is, regarding the fasting blood glucose, we can't use the fingerprint test to diagnose type 2 diabetes. The fasting blood glucose should be plasma blood sample. Is that correct?
Yeah, so most of the time as inpatients, we don't use the finger prick test. However, if the patient obviously is in the hospital all the time and we are monitoring their fasting plasma glucose, then the nurses do sometimes use the finger prick test. However, to confirm a diagnosis, it's a fasting plasma glucose, then yes, we would need to take a blood sample.
Okay, so I'll now move to my presentation. Okay, so my presentation will be focusing on the pharmacotherapy, the management of any type 2 diabetes. So at this point, I'd like just to remind everybody that we have our second part of our CPD series in diabetes next week. And this will offer you a very comprehensive and detailed look at the different pharmacotherapy options that are indicated in the management of diabetes. So today, what I'll be presenting to you is very much an overview, a little bit of information about the mechanism of action, and some general information about some of the class of medications that are used in type 2 diabetes. So the learning objectives describe the mechanism of action of the medications indicated in the management of diabetes, determine the choice of medication therapy in the management of type 2 diabetes, and examine the different types of insulin indicated in the management of diabetes. Okay, so before I start my presentation, I'm going to start with some questions. Okay, so by the time type 2 diabetes is diagnosed in patients, beta cell function is reduced to approximately what percent? Okay, you don't need to provide your answers now. By the end of this presentation, you should know the correct answer.
Dr. Zakaria, before you go on, I think we have a question here from the chat from Muhammad. He says, recent studies show that diabetes is less pancreatic disease, but more of a metabolic disorder. If your liver is fine, then everything is fine. Is that true? So
I don't know the answer to that question.
So maybe I can give a little bit of a hint to the question, to the answer. So when we say metabolic disorder, it's actually a group of conditions, and it's more appropriate to say metabolic syndrome, which is a cluster of conditions that includes a certain BMI, a specific level in lipids, perhaps a specific level also in diabetes. So it is not a disorder of the liver. So I wouldn't say it's true to link it to just the liver. I hope I answered your question.
Thank you, Ms. Mariam. Okay, so the second question, so which of the anti-diabetic therapies is described below? So it lowers blood glucose by inhibiting glucose production in the liver, enhancing peripheral muscle glucose uptake, and reducing intestinal glucose absorption. So which of these classes of antidiabetic therapy matches this description? Got sulfonylureas, biguanide, SGLT2 inhibitors, or DPP4 inhibitors?
We have Ala saying B. Muhammad is also saying B.
Okay, so some people are coming with some good
Jajamar B.
Okay, so by the end of my presentation, everybody should be able to answer these questions. So which of the following antidiabetic therapy is contraindicated in congestive heart failure? So sulfonylureas, glitazones, SGLT2 inhibitors, or DPP4 inhibitors? Okay. And someone's giving some answers?
So Ala, I believe, is saying B. Oh, we have variation here. So Muhammad is saying option D, Jajamar option C.
Right.
MD Sanullahi, if I'm pronouncing the name correctly, is saying option B. So we've got options between B, C, and D. Anyone saying A?
Okay, okay. So that's encouraging. So it means that you're going to go away with some learning today. And the final question before I start, regarding the use of insulin in type 2 diabetes, which of the following statements is true? So the onset of long-acting or slow insulin is roughly 90 minutes, and the duration is up to 24 hours. When insulin therapy is started in adults with type 2 diabetes, metformin therapy should continue for people without contraindications or intolerance to metformin. Rapid-acting and long-acting insulin has a clear appearance, whereas intermediate-acting insulin is cloudy. And approximately 50% of patients with type 2 diabetes will require insulin therapy within 6 years of diagnosis. So which of those is true? Okay,
so we have Ala saying B.
Okay.
Let's see, I think others are still thinking about it. Jajamar B, Muhammad B and C.
Okay.
Majority is saying B, yeah.
Okay, okay. So we'll go through those questions again at the end. Okay, so just a brief recap. Okay, so in this this first picture here, this first diagram here, you can see in a healthy individual, the pancreas, the beta cells in the pancreas, they produce insulin. The insulin acts on the insulin receptors on various cells around the body, which causes the uptake of glucose into cells, and thereby reducing the plasma level of, the levels of glucose in the blood. So this is in a healthy individual. Type 1, this is where you have the autoimmune destruction of the beta cells in the pancreas, and therefore you're not having this same insulin release as you do in a healthy individual. And then an overview. So in type 2 diabetes, you have this gradual decline in beta cell function in the pancreas. So you have this diminishing insulin release. And you also have this insulin resistance that the previous two speakers have spoken about, whereby the cells in the periphery, they are no longer receptive to insulin. So you don't have the same uptake of glucose into cells, and therefore you have higher glucose levels in the blood. And this leads to the microvascular and the macrovascular complications that we've already spoken about. So by the time that type 2 diabetes is diagnosed, beta cell function is reduced to approximately 50%, and it will continue to decline regardless of therapy. So the decline is about 5% per year in patients with diagnosed type 2 diabetes mellitus. So I just want you to think about your patients then. So patients, that they could be adhering to their medication, they could be adhering to the lifestyle modifications that have been recommended to them, but they're still being told that their glucose, their blood glucose monitors are impaired, that their blood glucose levels are impaired, and that their therapy may need to be optimized, may need to be intensified. So how do you think that patients are going to be feeling? They're going to be feeling demotivated, demoralized. So that's why it's important that all healthcare professionals, they have an understanding about the basics of diabetes and the effects on the body. So we can actually reassure our patients, to support them and to encourage them. So just continuing our recap. So as we've mentioned, so when we eat, so following a meal, the blood glucose levels, they rise. Carbohydrates are broken down in the stomach and in the intestines to release carbohydrates, these simple sugars. And the pancreas responds by releasing insulin. So this insulin, then what happens to it? It's released into the blood, and it can be stored as glycogen in the liver and also in the skeletal muscle. So it's stored in the cells in the periphery, and it's stored because it provides immediate available release. It's converted to ATP, and the body stores it for this purpose. So what happens in the absence? So when blood glucose levels, they fall too low. So if this is the case, what happens is that alpha cells in the pancreas, they release another peptide hormone. It's one called glucagon. So don't confuse that with glycogen. It's called glucagon. And glucagon almost has the opposite effect to insulin. Glucagon, what it does, it breaks down the glycogen into glucose, thereby raising glucose levels in the blood, making glucose available for energy production. So this is a very simple, sort of like a simplistic overview of what happens. And I think it's a good place to start, because once you have the understanding of this, you'll be able to comprehend how the drug therapies mode of action. Okay, so just to reinforce this point, so this is very important here. So patients, they're initially managed with a combination of restriction of energy and carbohydrate intake and an increase in physical activity. And this remains true throughout. So these lifestyle modifications that are really emphasized in pre-diabetes, they should continue throughout the patient's journeys, and they should be emphasized by all healthcare professionals whenever they have an opportunity for a review of their medications, or whether there's interaction for another reason with the patient. So NICE, this is a UK-based body. They suggest that anti-diabetic drugs should be commenced when HbA1c rises to 6.5%. So this is a bit of revision from what the previous speakers have spoken about. And patients should be made to understand that anti-diabetic drugs are intended to augment the effect of diet and exercise, and not to replace them. So again, we should be emphasizing the need for ongoing lifestyle modifications. The therapy is intensified if HbA1c is greater than 7.5%. So on review of the patient, whether that's an annual review or before then, where it could be 3 months or 6 months, depending on the stability of the patient's diabetes. If we identify that the current therapy is inadequate and the HbA1c has reached 7.5%, then we would consider intensifying therapy. And the earlier that we can intensify therapy, once the patients reach that threshold, then the better chance of prolonging the absence of micro and macrovascular complications. So for adults taking anti-diabetic medications, they should be supported to aim for an HbA1c level of 7%. Okay, so there's 7 different groups of oral anti-diabetic agents and 2 injectable agents. So for those of you who are very observant, you'll see that that's a total of 9, yet in this diagram here, I've only listed 8. So can anybody tell me the other injectable agent that I haven't included in this diagram? So GLP-1 agonists, these are injectable. What's the other injectable therapy used in the management of diabetes? Can anybody tell me? Yes, well done. Yes, Miriam?
No, I was going to read the response from Ala, insulin.
Excellent, insulin. So Ala, bonus point. So for the purpose of this presentation, we'll be talking through all of these therapies apart from these 2. So the 2 that we're not going to be talking about are the meclantonides and the alpha glucosidase inhibitors. And the reason for that is they've very much been superseded the drugs available to us now, they have a better efficacy and safety profiles. So we won't be touching on those. We'll be talking about the other therapies. They, in general, they have different mechanisms of actions, and also their primary site of action it does vary as well. And each agent has its place in the management of type 2 diabetes. So we'll start off by talking about biguanides. Biguanides, there's actually only one biguanide, and this is metformin. And so metformin is the most commonly used anti-diabetic agent. It's an oral anti-diabetic agent. It can only be administered orally. And it has 3 mechanisms of action. So it inhibits glucose production in the liver. So it works on the liver to inhibit what's called gluconeogenesis. So it's inhibiting glucose production in the liver. It also enhances the peripheral muscle glucose uptake. So it makes the muscle cells more sensitive to the effects of insulin. So therefore, muscle cells, they uptake more glucose, and it also reduces the intestinal glucose absorption. So less glucose is absorbed from the food that you eat. So all of these together, they help to reduce the blood levels of glucose. Has 3 mechanisms of action. So it acts in the presence of endogenous insulin. So it only works for patients who still have functioning beta cells in the pancreas. The standard release metformin is the first-line drug of choice for adults with type 2 diabetes. So if there's no other contraindications, so if this patient has no reason that they shouldn't be taking metformin, or they're not intolerant to the medication, then this tends to be the first-line treatment. There have been some updates recently in the ADA guidelines that if patients present with HbA1c that is I think it's at 10%. I think no, 1 to 2% above the recommended threshold, then we can begin more aggressive therapy, and we're going to touch on that a little bit later. So it does not cause an increase in insulin secretion. So, and therefore it doesn't have an effect on weight. So some of the anti-diabetic therapies, they do cause weight gain, and there is a risk of hypoglycemia. However, with metformin, it's less so associated with these side effects. So if monotherapy fails, so if using metformin alone you're not able to control the HbA1c, we can consider dual or even triple therapy alongside metformin. So and the current ADA guidelines, they do advise that we continue therapy with metformin throughout, as long as it's not contraindicated and as well as it's tolerated. We should consider it throughout the patient's treatment alongside additional therapies. So metformin, it should be used in caution in patients with renal impairment and hepatic impairment. And the most common side effects with metformin are GI side effects. Most notably, it's more associated with diarrhea than it is constipation, but constipation can occur. Tends to be abdominal pain and increase in flatulence. These side effects, they can be minimized with a slower titration of the dose. So say, for example, if the patient has been prescribed 1 tablet 3 times a day, what we can do, we can taper up the dose slowly. So the patient takes 1 tablet once a day for 1 week or even 2 weeks, depending on any adverse effects that the patient's experiencing. So we can titrate up the dose according to the patient's response and according to the side effects they may be suffering with. There's also an extended release preparation that's available. So this extended release preparation, there is some evidence that it's less associated with the side effects that are problematic with the normal release. The next class of antidiuretic therapy is sulfonylureas. Okay, and the way that I remember, that helps me to remember how this works, is you can almost see from this diagram. So the pancreas is this, I think you can see my cursor. So the pancreas is this diagram here. And how sulfonylureas work, they almost squeeze the pancreas, if you like. They squeeze the pancreas to help to help release exogenous reserves of insulin. Okay, so they stimulate beta cell insulin secretion, and therefore they're only effective if there is an endogenous reserve. So if there are still functioning beta cells in the pancreas producing insulin. So unlike metformin, unlike biguanides, they are associated with hypoglycemia. So they can cause hypoglycemia because they are releasing more insulin. And therefore, it's important that we're giving the lowest adequate dose for the patient. So we should monitor patient response and just give the lowest dose that helps to achieve HbA1c control. The side effects, they can cause weight gain. They can cause GI disturbance. Rarely they can cause hepatic dysfunction. And similar to metformin, they should be used in caution with patients suffering with renal or hepatic disease. So the next class of drug that we're going to talk about is glitazones. It does have a more complicated name that I struggle to pronounce, so we'll call them glitazones. And currently in Qatar, we're only using pioglitazones. So there have been other glitazones in the past, but in Europe, well, in some parts of Europe, they have now been withdrawn because of their safety profile. So how do these work? So these increase insulin sensitivity by acting on adipose tissue and muscle to increase glucose utilization. So we see that they work by making the adipose cells and muscle cells more sensitive to insulin. Therefore, you see a greater uptake of insulin and a reduction in glucose levels in the blood. To a lesser degree, they also decrease glucose production in the liver. The side effects, these tend to be dose related. So with the higher doses of glitazones, we tend to see more intense side effects. And the most notably, these are increased fluid retention, anemia, and weight gain. Okay, so they're contraindicated in patients with heart failure. So glitazones, they're contraindicated in patients with heart failure with a history or a high risk of fracture. So this includes people like postmenopausal women who may have low bone density. They're also contraindicated in active liver disease, patients with active or history bladder cancer, patients with type 1 diabetes, and pregnancy. And because of their safety profile, prescribers, they should review the safety and efficacy after 3 to 6 months of treatment. So at baseline, so before starting patients on glitazones, patients should have their liver function tests performed, and then they should be monitored throughout to make sure that we're giving the lowest effective dose to control HbA1c levels. Okay, so the next class we're going to be talking about is SGLT2 inhibitors. Okay, these have quite complicated names, but I'm hoping that we can try to simplify it with the diagrams that I have for you now. So there's quite a few number of these drugs. The most common ones that we use here in Qatar are dapagliflozin and canagliflozin. And how do these work? Okay, so we discussed earlier that when after we eat, the carbohydrates in our diet, they're broken down into simple sugars, into glucose, and this happens in the stomach and the small intestine, and then the glucose is then released into the blood. So when the blood then passes through the kidney, the kidneys, they recognize the glucose as a potential energy storage and a useful molecule for the body to keep. So therefore, we see a reabsorption of glucose within the kidneys. We see 90% of this reabsorption in this proximal tube, this S1 segment, and a further 10% in the distal segment of the proximal tube. And this glucose, the reabsorption occurs through these sodium glucose transporters. So this is how this reabsorption occurs. So these drugs, how do they work? They actually block these transporters. They block these transporters in the S1 and the distal S2, S3 segment of the proximal tubule. So therefore, you're not going to have the same, you're not going to have this glucose reabsorption. The glucose is going to remain in the kidney and then excreted in the urine. So that in patients using these medications, they will have a high concentration of glucose in their urine. And as you know, where there's a higher concentration of glucose in the filtrate, you'll see the natural movement of water into the filtrate as well by osmosis. So for patients using these medications, they tend to pee greater volumes and tend to pee more frequently as well. And therefore, they are at risk of developing symptoms of dehydration. So they may suffer with what's called postural hypotension and feeling dizzy and lightheaded. So therefore, in the presence of hypovolemia, so in the presence of things like dehydration, that should be corrected before we even consider starting therapy with this group of drugs. And I think this is quite, you probably would have guessed that patients who suffer with renal dysfunction, their kidneys aren't functioning as well, then we should use these drugs with caution. And then those patients that are suffering with moderate or severe renal disease, they're actually contraindicated. Okay, so the next agents are these GLP-1 agonists. And up until recently, these were administered subcutaneously. There is now an oral therapy available as well. And these are either administered on a daily basis or a weekly basis. And how do these work? Okay, so as we eat and the food passes through our intestines, what happens is a peptide is released, and this peptide is called GLP-1. And remember that name. That's an important name for the next group of medications that we're going to talk about as well. Okay, so GLP is released, and GLP receptors appear in many different places in the body. Okay, so it appears in the brain, in the gut, in the liver. So when GLP is released, it acts in many different places in the body. And the effects that this has is that it induces satiety it induces a feeling of fullness by acting on receptors in the brain. It also slows down gastric motility, so it slows down the movement of food in the gut. So you get this slower absorption of glucose. And in the liver, what it does, it inhibits glucagon secretion. So if you remember, glucagon breaks down glycogen into glucose. So it inhibits this process. So you can see by those actions, you're going to have a resultant lower in blood glucose levels. So what we tend to see with this group of drugs, we tend to see they're very effective in lowering HbA1c by 1 to 2%, and they actually produce a weight loss of 2 to 5 kilos. The most common side effect with this group of drugs, because they act on the GI tract, they commonly cause nausea in about 25% of patients. Okay, so I told you to remember that name, GLP-1, because this next group of drugs also involves GLP-1 as well. So this is our DPP-4 inhibitors, and there's quite a few of these as well: alogliptin, linagliptin, sitagliptin. So this group of drugs. Okay, so remember what the effects of GLP are. So we said that receptors, they appear in many different places in the body, in the brain, in the gut, in the liver. So how this group of drugs work, they actually prolong the life of GLP. So there is an enzyme that breaks down GLP-1, and this enzyme is called the DPP-4 enzyme, and it inactivates GLP-1. So what this group of drugs does, it actually stops the actions of this enzyme. So it prolongs the life of GLP-1. So therefore, what you're going to have an ongoing action to induce satiety by acting on the receptors in the brain. You get suppression of glucagon secretion, so you're not having that conversion of glycogen to glucose in the liver. You're also stimulating insulin secretion as well. So these are administered orally. They're weight neutral, so they don't have the same effect to reduce weight, but they do reduce HbA1c, not by the same levels that we see with GLP-1 agonists, but they do reduce HbA1c. So we only continue therapy with this group of drugs if the person has a beneficial metabolic response. They're generally well tolerated, with few common side effects, but a common one, well, I wouldn't say a common one, but associated with all of these DPP-4 inhibitors is severe joint pain, but it's not common. Okay, so that's the drug therapies that we're going to cover in the presentation. What I'm now going to talk to you about is the management on how we use these drugs. Okay, so in Ms. Zara's presentation, she mentioned that when HbA1c levels rise to 6.5% and the patient is maintaining their lifestyle modifications, and a diagnosis of type 2 diabetes is confirmed, this is when we would consider so this is when we would consider therapy with anti-diabetic drugs. And I've mentioned already that the first drug that we consider is the standard release metformin. Okay, and again, I'd like to emphasize as well that at this point we are still emphasizing the lifestyle modification. So we offer the standard release metformin as the initial drug therapy. And we try to support the patients to aim for an HbA1c of 6.5%. Okay, so that's what we're aiming for. So I mentioned to you earlier as well that there has been a recent study. It's called the Verify study, and this indicates that in patients who are presenting with A1C levels that are 1.5% or 2% above the target, we can treat. The initial treatment can be more aggressive. So we can start the patient on dual therapy. So we would start them on metformin as well as a DPP-4 inhibitor. So something like sitagliptin or saxagliptin, for example. So this is in patients who are presenting with a HbA1c that is 1.5 to 2.5% above the target. Okay, so when do we consider intensifying therapy? So we consider intensifying therapy. Well, this shouldn't be delayed. So although it shouldn't be delayed, we do need to reassure ourselves that the patient, they are adhering to their medicine. So before we consider intensifying therapy, we need to make sure that the patient is taking their medications as prescribed. Okay, so we consider intensifying therapy if the patient is HbA1c reaches 7.5% whilst using metformin. And what oral antidiabetic therapies do we consider? So we consider adding a DPP-4 inhibitor, or pioglitazone, or a sulfonylurea, or an SGLT2 inhibitor. And again, we're trying to support the person to aim for an HbA1c level of 7%. So I know what you're thinking. You're thinking, which of these options do we choose? So this is very much, there are many factors that are going to affect our decision. So that we need to consider maybe other comorbidities the patient is suffering with, their hypoglycemic risk, the impact on weight. We need to consider cost, the potential side effects of the medication. So there isn't one answer. We cater the therapy to the specific patient that we're treating. And this, I'm not going to go through this slide. This is what is going to be covered in next week's presentation, when we consider a bit more in depth the profiles of each of these medication groups. So triple therapy again. So we intensify treatment if HbA1c reaches 7.5%. So the patient is taking dual therapy, yet the HbA1c is still coming back at 7.5%. It's still being tested and reaching 7.5%. And then what do we, what's our therapy options? So we consider metformin as well as DPP-4 inhibitor, and then consider maybe adding sulfonylurea. Or we consider adding pioglitazone as well as sulfonylurea. So these are our options, and the target HbA1c is 7% that we're trying to achieve with the patient. The final steps that we could include, so if we find that our oral antidiabetic therapies are unsuccessful in maintaining that 7% target, then that's when we can consider starting insulin therapy. So we're just going to talk a little bit about insulin therapy. So I think I've mentioned already, I just want to emphasize this point, the ability of the pancreas to produce insulin in patients with type 2 diabetes decreases by around 5% per year. So ultimately, 50% of patients with type 2 diabetes will require insulin therapy due to beta cell exhaustion within 6 years of diagnosis. So that's taking into account, patients who are adhering to their lifestyle modifications and optimizing therapy. 50% of patients will require insulin therapy within 6 years of their diagnosis. When insulin therapy is started in adults with type 2 diabetes, metformin therapy should continue for people who don't have any contraindications, or they are, as long as they're tolerant to the medication. So what are the types of insulins? And again, this is going to be covered a lot more in depth in our future sessions. So the types of insulins, you've got your rapidly acting insulin, which is fast to start working. It works within 1 to 2 hours, but the onset is 10 to 15 minutes. The peak is with 1 to 2 hours, and the duration is up to 5 hours. You then have your intermediate acting, and this usually has a cloudy appearance. It takes a little bit longer to start working, within 1 to 3 hours, and can last for up to 18 hours. And then you have your slow or your long-acting insulin, and the onset is within about 90 minutes, and the duration is up to 24 hours. So very brief, there are other types of insulin, but as an overview, these are the ones that you should be aware of. So now it's time to go back to the questions that we looked at the beginning of of my presentation. So by the time type 2 diabetes is diagnosed in patients, beta cell function is reduced to approximately what %? So I'm hoping that everybody can tell me the correct answer now. So Ala is telling me B, Sarah is telling me B. Good, everybody's giving me the right answer. Muhammad is telling me B as well. Very good. So it's 50%. Next question. So which of the antidiabetic therapies is described below? So 3 actions: lowers blood glucose by inhibiting glucose production in the liver, enhancing peripheral blood glucose uptake, and reducing intestinal glucose absorption. So which of these? Good, everybody's giving me the right answer. B. So the correct answer is B, biguanides. And we only have one biguanide, and that's metformin. Okay. Which of the following antidiabetic therapy is contraindicated in congestive heart failure? So the sulfonylureas, glitazones, SGLT2 inhibitors, or DPP-4 inhibitors. So most people are telling me B. There's some people telling me D, so that's not the correct answer. The correct answer is B. So glitazones, they're contraindicated in congestive heart failure. So they shouldn't be used in patients suffering with congestive heart failure. Good. Okay, so regarding the use of insulin, which of the following statements is true? So the onset of long-acting or slow insulin is 90 minutes and duration is up to 24 hours. When insulin therapy is started in adults, metformin therapy should continue for people without contraindications or intolerance. Rapid-acting and long-acting insulin has a clear appearance, whereas intermediate acting insulin is cloudy. Approximately 50% of patients with type 2 diabetes will require insulin therapy within 6 years of diagnosis. So in fact, all of these are correct. So all of these answers are correct. So I didn't give you an option E, which would have said all of the above. So all of these answers, well done, Mohammed. You told me that all of them are correct. And excellent, Alia as well, very good. You're able to tell me that all of these are correct. Okay, so in summary, Patients with type 2 diabetes, they're initially managed with a combination of diet and exercise. Anti-diabetic drugs should be commenced if HbA1c is 6.5%, and therapy should be intensified if HbA1c reaches 7%. There are 7 different groups of oral anti-diabetic agents, 2 injectable agents for the treatment of type 2 diabetes, and metformin is generally the first drug of choice. Glitazones increase the risk of congestive heart failure, but not the overall risk of cardiovascular death. Beta cell function will continue to decline regardless of therapy. Therefore, there is a constant need to review and intensify therapy and support patients and encourage patients. Ultimately, 50% of patients with type 2 diabetes will require insulin therapy within six years of diagnosis. So that's the conclusion of my presentation. We now have some cases that we're going to discuss with you. The first case, Ms. Miriam will be supporting me with this case. So, Ms. Miriam, would you like to read through this case?
Yes, sure. So we have here Salim. He's a 67 years old Qatari man who owns a business and is coming for a regular checkup at the primary clinic. He's diagnosed with hypertension, controlled, and he takes lisinopril hydrochlorothiazide, 10 to over 12.5 milligram. That's the strength. He's also diagnosed with dyslipidemia, for which he's taking atorvastatin 20 milligrams, vitamin D deficiency, takes vitamin D 50,000 international units weekly, and he's also taking a multivitamin, which is the Silver Centrum. So this is, I think, we're trying here to give you an overview of a typical patient that you might see in practice, with very, very simple questions. So you, the healthcare provider, is interviewing or managing Salim's case. You look at him, he's unwell, he's a little flushed, he says he's a little breathless, he gets up at night to pass urine 2 to 3 times at night, and attributes this to the fact that he's drinking a lot of water during the day, he's feeling thirsty, and he has a bit of blurred vision. His BMI is 32, and he is currently a smoker. Dr. Zak, do you mind going to the next slide? So here we have a question: what are the signs and symptoms presented in his case that are consistent with diabetes diagnosis? And please enter your responses in the chat. Polyuria, very right. Hyperglycemia. If I manage to give you a little bit about the blood glucose, which I didn't in this case, but if I would do, it would be high. Obesity is a risk factor, not a sign and symptom. So just to highlight, don't confuse risk factors with signs and symptom of the condition. Signs and symptoms basically are what the patient is presented with that are consistent with the diagnosis of diabetes. Risk factors are what are the predisposing basically factors for the condition. So you're right, polyuria, hyperglycemia, again, if I give you the results. So feeling thirsty, this is termed, if I remember correctly, polydipsia. Polyuria, going to the washroom too much, and then we've got also the fact that he has blurred vision. So unfortunately, we forgot to remove the answer from the next slide. So we have a question here that says, can you go to the, which of the following basically represents the diagnostic criteria for A1C? For diabetes, I mean, and all of these values, you might see them in a patient who has pre-diabetes sometimes. So the fasting blood glucose above 100 or a random blood glucose above 120, you might want to look at the results more closely, but really the diagnostic criteria based on the slides that we've presented today is an A1C above 6.5. One of the questions that popped up in the chat was about, do we take plasma or the finger prick? Now, a lot of patients are being screened in clinics through the finger prick, and whenever the levels are high, this is when you want to, take a blood sample just to assess the A1C so that you have at least 2 readings to diagnose the patient. The next question, I think, is also having an answer. Let's see. So here we have, which of the following can you offer Salim to support him in gaining diabetes-related information in Qatar? And this goes back to our initial slides. So there is the Drubi application that you can ask Salim to download and try to, see the information that is available to him through it. There is also the HMC webpage that has a lot of information about diabetes. They have actually a lot of electronic brochures in both English and Arabic that a patient or a healthcare provider can download and use for reference. Enrolling him in the course for educators is going to be a little bit too advanced because they're using the course for the purpose of diabetic educators. And we have to register him in an annual diabetes conference for healthcare providers. Of course, this is not really realistic and it's a bit too much for a patient. The next question we have is, Dr. Zach, do you mind? So again, I'm sorry we have the answers already highlighted for you, but just like a way of reminder. So here he was confirmed to be type 2 diabetes. His physician is starting him on metformin. Basically, the question is, which class of medication does metformin fall under? And biguanides is the correct answer. A lot of us, we don't use the term biguanides as described by Dr. Zach. The only agent that we typically have within this class is metformin. So we typically just say metformin as a class. And I think that the next one would be the last, if I'm not mistaken. So the most common side effects with metformin is which of the following? GI-related weight gain, hypoglycemia, or increased lipid levels. And the correct answer is actually GI. And a lot of patients, once they start metformin, the first thing you want to tell them is take it with food. Avoid taking it on an empty stomach. And if the patient is still experiencing the side effect, you might want to switch the formulation from an immediate release to an extended release as described by Dr. Zach. I think this is the last question for this case. Yeah.
Okay, thank you very much, Ms. Marine, for going through that case. And that concludes today's session. So just as a reminder, for those who have joined us a little bit late, I'm just going to show you how you'll be able to claim your CPD certification. So I'm going to share my screen with you. Okay. Okay, so if you go to our website, you'll go to our events. So our CPD events are okay. So to claim your certification, you'll just need to complete the CPD evaluation. So by clicking on this link here, it'll take you to a short survey. So this link will become live today at 8 p.m. So you can access that link at 8 p.m., complete the questionnaire, and then you'll receive your presentation. You'll receive your certification within 7 days of today's session. But please do complete it in the next 7 days because the link will expire after 7 days. At this point as well, I'd like to draw your attention to our next session. So next week we'll be focusing on diabetes medication review and optimization. So we have 3 excellent speakers. Ms. Marine will be joining you again. We have Dr. Maggie Al-Hajj and Dr. Sarah from HMC, and they'll be talking to you about the medications and optimizing medication in the management of diabetes. So please join us for that session. And as always, we encourage your feedback. So any feedback that you have on today's session, please do get in contact with us. Either email us, or you can email us, or you can put it in the chat section here, and we'll take that away with us. So finally, I'd just like to thank our speakers today. Very interactive presentations, very comprehensive. And thank you again to our audience who participated with your interaction as well. And I look forward to.
We have one question, Dr. Zach.
Sorry. Yeah, 1 second. Sorry. So, if the blood tests for screening diabetes are contradictory, which one would you recommend to be repeated? The one with normal value. Sorry, other people are writing, so I can't see what this one says. The one with normal value or the one with abnormal value to confirm the diagnosis. So I think you've actually answered that question with your question. So if the diabetes tests are contradictory, you would just repeat the test. So you can repeat the HbA1c. It's fairly an inexpensive test. Similarly, with the random blood glucose test, you can repeat that test as well. So you could repeat both of those tests. Okay. Okay. So again, thank you to our speakers today, and thank you for our participants for attending and participating. And I look forward to seeing you next time. Thank you very much, everybody, and good night.